Well, first of all, thank you very much for inviting me over for this webinar on integrated care evaluation, moving from theory to practice. Something about my background. I'm a researcher. I did a PhD on integrated care evaluation, and I'm linked to the University of Maastricht, University Medical Hospital, and I'm the vice president of a research consulting company called Essenburgh. And 2 years ago, we set up integrated care evaluation as an initiative to increase the level of evaluating integrated care projects around the world. And the essence of this presentation is summarized with this sentence, I would say. Knowledge is of no value unless you put it into practice. That's what I believe, and that's why we start evaluating integrated care. We have a lot of theoretical models, and they're fine, but how to execute it in practice, that's the biggest challenge we have in the market right now. So that's why we set up integrated care evaluation to say, okay, how can we speed up the theoretical thoughts in practice? And for the next, approximately 30 minutes, I want to discuss with you these 3 topics. First of all, why integrated care? Why do we need to focus on it? What's the rationale behind it? Second, how to measure it? How can we measure it? How can we comprehensively measure all the aspects of integrated care? And third, if we measure it, what do we see in practice? What building blocks do we see? And can we compare countries, clinics, based on patients and provider experience? So, first of all, why integrated care? Well, I think you're all familiar with these kind of fragmented healthcare problems, and this is mainly caused within high income. This is the case in high income countries. We have a fragmented healthcare system, which is caused by regulation, by financial incentives, but also by a specialized mindset which is deeply embedded within our healthcare system. And here's the example of the fragmented care solutions we have in place between primary care and secondary care, but the same applies also between primary care and social care, and so forth and so on. And if you notice that we have a fragmented delivery system, we also know the global trends in terms of healthcare cost and the disease burden. So first of all, here you see what are the total costs of our healthcare system across the globe. This is an old number. It increased over the last year, but you see that this number is increasing. We almost spent like $7 trillion on healthcare. And the needs are also increasing. We already know that 50% of the disease burden in OECD countries is represented by people with multimorbidity, so people with 2 or more chronic diseases. And the way we deliver currently our services do not fit the needs of those people. And on the other hand, we have an aging population across the globe, and mainly in our high-income countries. This is a number of increasing people of 65 to 70 years old within the next 4 years within the Netherlands, but this number also applies for other countries. So if you know this is the demand, and what we have organized on the supply side, we see a big gap. So first of all, as already said, we have a fragmented delivery system which is caused by a poor coordination of care across the care continuum. And this is caused by a lack of accountability across care providers. Who's accountable for someone with a high or complex need? How should we organize that? It's ambiguous who is accountable for that. Third, what we also see in many countries is a misalignment of payment incentives, which cause the lack of accountability and poor coordination. And fourth, there's a little transparency in cost and health outcomes, which makes it very difficult to determine the effect of another way of organizing a healthcare system, because there is a lack of transparency in those data, especially the cost data. And if you look in the literature, there are some articles or several articles that estimate that approximately 25% of all patients are harmed by medical mistakes, and those medical mistakes are caused by poor communication and poor coordination of care. So actually we are causing harm to patients while we're not organizing the care properly. And last but not least is the waste of funds within our healthcare system. it depends on the context or country you're looking in, but like on average, like 30 to 50% of all funds we put in our healthcare system is a waste of money, and it's a waste because we have a lot of duplications within our system in terms of medicines and services provided. So if you see this picture, I think it summarizes a bit the gap and the challenge we have across the globe to address this gap and to organize it more in an integrated or connected way across the care continuum. And if you look in the current literature, you see basically a trend across the globe from the shift from a volume to a value-based healthcare system. And what do we mean by that? I try to summarize that in this table. We have in payment, we have different payment models. We're now moving from a fee-for-service model towards a more shared risk, shared reward kind of model, where the different providers included get an incentive to coordinate the care better. I have a lot of initiatives across the globe that try to implement these alternative kind of payment models. And the incentive is based, where it was previously on treating diseases, we now also try to incentivize prevention, to prevent a disease from happening, which is very difficult, but it's the new way of thinking in reorganizing healthcare. And the focus is moving from the individual patient towards a population, and that's called population health management. And some people say the other way around, the focus is from population towards an individual patient. But I say it like it's moving from patient to population, basically because we have our statistics are better to predict an adverse outcome on a population level than on an individual patient level. That's pure statistic. And if you see at the provider, where we currently everyone for themselves, which basically incentivizes a siloed approach, I would say, we're now moving towards joint contracting, where people are collaboratively accountable for the outcome they achieve or don't achieve. And last but not least is the information, where we used to have like focus on retrospective data. We're now moving to predictive, real-time and lifelong data models. So we're able to predict what are the adverse outcomes in the nearby future for a population. And that gives us tools to organize it in another way, which makes it possible to organize it in another way. And I already said a couple of times, we're moving to a value-based kind of approach. And what do I mean by that? And there are basically two ways to conceptualize that, and I think it's important to distinguish that. First of all is the value-based healthcare approach of Michael Porter, which says quality divided by cost is patient value. Very simple. But if you look closely at that literature and the articles published, and this is really from a scientific perspective, that's nothing more and nothing less than a disease management kind of approach. It's a disease-specific approach, which has its value, but also has its shortcomings. Because from a scientific perspective, there is a quality industrial logic behind it that an intervention here, A, leads to B, a better outcome, a linear relationship, which we call a reductionism approach, which we focus on symptoms, we address that, and the outcome will improve. Very simple, but that's basically the way of thinking on value-based healthcare. On the right-hand side, we have another approach, which is more person-focused, I would say, and this is basically summarized in the work of Donald Berwick, triple aim approach, who says you have like 3 aims you have to target at the same time. Improve population health, reduce cost, and improve the experience of care for patients, and I would say across the care continuum. Basically, what's interesting about the triple aim, that its foundation is embedded in public health, primary health care. And I will say later in this presentation why this is important, and it is important because there we have the evidence that this approach leads to better outcomes. And that's basically why I think it holds more true in this situation. And if we look at the science behind it, we call about interdeterminism. So we look at different aspects that correlate with each other and lead to a better outcome or not. But it's not completely understandable. You need to understand the pattern here, how an intervention or several interventions leads to a better outcome. And that makes it complex, and it makes it complex because our statistics are not yet ready to deal with this complexity here. It's improving, but that's the way. This is difficult to realize this in practice, also based on a statistic approach. We don't have yet the models that can explain all the complexity here, how an outcome is created for a certain population. And if we move further with this in mind, so having like value-based healthcare on the one hand side and triple aim on the other hand side, and the different knowledge perspectives behind it, there is a changing paradigm. Where the traditional perspective, we talk about a reductionism approach, a determinism, we focus in the knowledge on certain elements. And there we focus on and we try to improve that. Well, more from a complexity adaptive system approach, it's about a holism approach, like the person focus looking in the total context, and we focus on interdeterminism, and we focus on how the different elements within our system interact and start to understand that pattern, what happens. So the scientific knowledge is moving from knowable to understandable by pattern observation, and that's something completely different than we used to by running just on the left-hand side a regression analysis, by here understanding how the outcome is produced in a particular population. The design principles are also different. While we, on the left-hand side, within a disease-specific approach, we focus on efficiency, and here we have something called agility, learning and innovation, and starting to understand how outcomes, interventions can implement and how we can create a better outcome. And last is the design principle or philosophy. It's here we talk about the hierarchical approach, and here we talk about the hierarchy approach, which is more a bottom-up approach or a bottom-up and top-down approach. And this is important why I explain it so extensively, because if you are evaluating or designing an integrated care program or model or organization, you need to know which kind of paradigm or knowledge type, scientific paradigm, design principle or philosophy you choose. You can mix them, but I think here on the right-hand side there is the real value created if we can start understanding this with each other. And then I'm always critical. I say, okay, what's new? What's new about this approach? And then I would like my audience, who is this lady? Yeah, 10 points for Mr. Goodwin. And she pointed out a few years, she basically laid a foundation of understanding what is creating value within a population by coming up with a definition or a description of what is primary care or primary health care. And the basic elements she summarized as, well, I could ask you that question as well. How do we define primary care, primary health care? Which elements?
Oh, first contact, care coordination, comprehensiveness, continuity.
Fantastic. You're the first one who know them all. Yes. There are more, but I think these are the basic elements. First of all, person-focused care. Looking at someone with a complex need or with a disease, also in a social context. That's what's called person-focused care. On the other hand, she also stated in her definition that's not only about the individual person-focused approach, but also the population-based approach. You're also accountable in a way as a provider also for your community or population you serve. So it's moving further than only your practice population. That's what she pointed out. Third is indeed the comprehensive care coordination kind of approach by providing your services. So across the care continuum, that's what she basically said. And fourth is the first contact of care before someone moves to specialty care within their healthcare system. But there needs to be some kind of track and trace principle by tracking patients with that complex need. And what's interesting, because she pointed out in several studies, and this is old, I know, but it's important to know what's creating value, because that we want to know, is that here you have a primary care score from 0, which is the worst score you can have, to 2, it's a fantastic primary care system. So it's benchmarked basically on these kind of elements. And she showed that countries that have this organized better have lower healthcare costs per capita, and the same figure she also presented, you can look it up in the literature, for the quality indexes. Also for health and for mortality, we see the same correlation patterns. So basically what I'm trying to say here is that she laid the foundation for what we now call population health management or integrated care, however you name it. Basically, she laid a foundation of what that is and how we can start measuring it and understanding it. So if we take that in mind, what I pointed out is the population-based approach. And we all know, we're all familiar, I think, with these kind of Kaiser triangles, how you can stratify a population based on clinical, social, and behavioral risks. And we know, based on several literatures, that the top tier here of the 6% within a population creates approximately 45 to 50% of the cost. It depends in which population or context you're looking at, but there is, so a small amount of the population with multiple severe needs is creating the huge amount of costs here. Below that, we have like 44% is responsible for 35% of the total healthcare cost within a population. And again, those numbers vary, but there is some kind of pattern here. And the healthy population is responsible for 20 up to 5% of the total cost. And basically what you need to do, and that's also pointed out by the work of Starfoot, what kind of interventions or approach do we need to have in place here for this 6% of the population, this 44% of the population, this healthy population. And then you come into the field which we call integrated care. And then when you start looking in the literature, you enter a black box. It's a complete mess because it's very badly described what the intervention exactly is. And that's also pointed out by this paper by Dennis Kotner in 2009. I always recommend to read this because he summarized perfectly the troubles we have with studying integrated care or understanding it. And also, if we can't understand it, we can also not execute it in practice. And basically, if you talk about integrated care, it's a blind man touching an elephant. So everyone only sees his own perspective, one piece of the bigger puzzle. And that's summarized here on top of this slide here by Mr. Kotner. Integrated care as a concept is an imprecise hodgepodge. Its meanings are as diverse as the numerous actors involved. And that's what it is. And he also pointed out in 2009 that it's not a mean, it's a mean to a certain end. It is a mean to a better outcome, as already expressed. If you then look at from value-based healthcare or triple aim, it doesn't matter, but it's a mean to a certain end. But we need to understand how the different elements create a better outcome. That's basically what we're looking for. So when I read this article back, well, in 2010, I suppose, then I thought, okay, what he also said is we need to have like a comprehensive model so we can model the different interventions and we start understanding how it works. And before I started with developing that model, something interesting is, if you talk about value and perspectives, people have different values and different perspectives. If you look at from the patient side, it's about easy access, navigation and through the care continuum. That's basically what a patient wants. And of course, he wants to have safe and timeliness care. But this, if you talk about care coordination or integrated care, this is what a patient wants. The second perspective is that of the provider, care provider, who needs to coordinate the tasks and services across the care continuum with other physicians. And he has some kind of accountability with his peers of it. The third perspective is the perspective of the manager. And that's another perspective. It's about quality, market share, and efficiency. It's another perspective, but it also, you need to take account for it. And the fourth perspective is the policy perspective, who's responsible for access, quality, and continuity of services. And if you put this together, we get some idea of how we can model integrated care or understand the different values and perspectives within this complex field. And that we try to bring together based on also the assumptions of Barbara Starfoot in the so-called rainbow model of integrated care, or rainbow model. So what we did, first of all, we start on the focus. What is integrated care about? And here you see person-focused care in the center of the model. And that's pointed out by the work of Barbara Starfoot, is looking as a person in a social context and looking at the people's needs and values and address them. But this is organized at the micro level in the interaction between a patient and a provider. But also we have here the population-based approach, population-based care. And that's the community or population orientation, because we have more than one person with a complex or high-risk need. And then you need to organize it at a different scale. That's basically what we're pointing out here at the meso and macro level. But you have to, these are the two focus principles how you can organize integrated care in practice. And if you then look further in what you can organize at the different levels, at the micro level we talk about services, and we call that service or clinical integration. That's the coordination of care at the individual patient level. And we only talk about integration for the individual patient level, as already said, only for someone with a high complex need. At the top, at the bottom of our pyramid I just showed, there we don't have to talk about integration. There's no need for it, but it's especially needed for the people with a complex need. So if we have a severe population here, then on the meso level, professionals also have to organize things together, and that's called professional integration or professional coordination of care among the different care providers across the continuum. And they're accountable together for the needs of the population here with the different complex needs. On top of that, we have the organizations, the different organizations who provide services within a community. And there that we call organizational integration, where the coordination of care among different organizational units. And on top of that, we have something called a system, and that's the influence of law and regulation or care coordination activities here on all those levels, which influence it if it happens or not. More interesting is how you can achieve it in practice, and that's called the enablers. On the left-hand side, we talk about functional enablers, or I would say the technical competence of people to organize it, and then we talk about the infrastructure to coordinate care, and then you should think of financing, new kind of payment models, data sharing, educating people in another way. And here we have the normative enablers, which is more the cultural components across the stakeholders, how they can coordinate activities, and then we talk about the shared vision, mutual gain approach, culture, all the more, well, I would say soft skills you need to integrate here on those different levels. And the assumption here is that if you integrate, if there is a huge population with a high need and a high cost, the assumption is that you need to integrate on all these levels to improve your outcomes according to the triple aim. So lower cost, improve health, and improve care experience by patients. So that's the assumption basically which we try to test and model here. So if we know which kind of forms or types of care coordination activities we have here, we might understand how does that relate to a certain outcome we see. So how do we measure it? Is it possible? Well, I think it's possible, but it took like 5 years to getting here, which you see here. It's like an overview of how we started. In 2013, we developed the rainbow model, which we tested in several expert panels, and we tried to, well, develop the different underlying elements or enablers of the different bows of the rainbow model in 2013. In 2015, we developed the first version of our measurement tool, which we piloted in Singapore, the Netherlands, and Australia. And based on the results of those 3 pilots, we said, okay, some skills, the different bows of the rainbow model had good reliability and construct validity, but other skills really need to be improved, especially the organizational integration part, system integration, and functional integration. So what we did a review of systematic reviews, looking at other instruments that already have been published, and started improving the measurement to 2.0, which we have now validated across 20 countries. And in 2016, we established ICE, Integrated Care Evaluation, because we also get a lot of requests to start evaluating this across the globe. And now we're running, well, several evaluation studies to start understanding if we can model how integrated care works. So we're slightly moving to practice. the development of the rainbow model measurement to 2.0, which we did according to the FDA guidance for development of patient-reported outcomes. So we had like a preliminary version of the measurement tool, and we conducted a review, systematic review, where we screened 234 measurements tools that already have been published. And we looked at the different scales and items that might be useful to construct an even better instrument. So we selected 85 potentially reliable instruments, and we ended up with 8 instruments or subscales better that we could use to improve our organizational system and functional integration scale. And then we designed it, and we had like several criteria to design it. It should be easy to use, so it doesn't should be a burden to complete by patients and by provider, and it should be a generic tool, so it should be applied across settings, across different patients with a chronic disease. Otherwise, we end up with a disease-specific approach, which doesn't work. And we, based on the pilots we did, we also get the recommendation we need a patient version to measure it from a patient perspective, which is called a patient-reported experience measure of care coordination. So that we did. So here you see the icons. The first domains they are measured by the patient version of the survey or questionnaire. And the assumption is that a patient only knows if he is provided, if he has a person-focused care approach, if the clinical services are correctly coordinated, if professionals are coordinating their care, and if it also is coordinated across organizations. That is our assumption. That is the only thing you could ask, the core, the essence of integrated care. Providers know more, and for them we also added 4 domains, so they know how, if they are entering in a population-based approach with their care facility, if they have in place a the functional capacities to coordinate care, the normative competence, or the cultural competence to integrate care, and if the system is helping to coordinate across the care continuum. So basically, providers have a longer questionnaire to complete. So what we did, we started testing the content validity in an expert panel, multidisciplinary expert panel, and we came up with very good content validity. And this is an index which shows you it has to be about 0.7, and on all the different scales we had, it was quite good. So we were ready to go to move in practice, but first of all we had to test it, a pre-test across patients if they don't think, if it was easy to complete and it was not bordering there in their daily lives. And we tested it among 50 patients with a chronic disease, and it came out, was easy to use, and well, it met all the criteria we had, which we were pretty happy with, because then we could move on. So this basically summarizes what the survey is and some of the validity measures. So the patient survey contains 4 domains of the rainbow model, as explained, 24 questions. On average, it takes a patient with a severe chronic disease 9 minutes to complete, which is quite okay. And the reliability varies per scale from 0.89 to 0.97, which is very good and above all the international thresholds. For care providers as well, 8 domains, 48 questions, on average 15 minutes to complete, a bit longer, and also good reliability from 0.86 to 0.95. And also we conducted a factor analysis to test the construct validity, and all those 4 and 8 domains came out of our factor analysis, which makes me very happy as a researcher, but it took 4 years to develop it. And here you see the different domains which we measured. Here you see the countries in which we applied the tool, and within the next slide we're going to look at some results. So if you are sitting in India, Africa, or the United States, please contact me, because then we have a global comparison. So, and that's what we need to really understand how it works. So what do we see based on our study we recently conducted? We're going to look at some preliminary results here. So And we look at the results from the patients, because I think that's the most interesting part here. They know best, at least, if they have a coordinated care experience or not. Here you see the different countries which were included in the study. And here you see the global average, how patients rated it. And basically we have here like 8 countries where patients indicated it's above global average. So we could say, well, it's a fantastic care coordination experience. And there are countries which scored below this threshold. And because we don't have a golden standard yet, we have to work with global averages to understand how countries are scoring. And I will focus on 3 countries. First of all, Australia, Germany, and the UK. Why those countries? Because my assumption was, before I started this research, these are countries which are ahead with their integrated care and care coordination policies, so they should score around here. But they didn't. And that's interesting. And why it is, I don't know, but this is what patients tell us. So let's have a look at the global person-centered care experience. Do patients experience that their needs and values are respected in their treatment, basically? Here you see a scatter plot. Here's the person-centered care score, and here's the average overall care coordination score, and here you see the global average per domain and overall. On the left-hand side, in the lower quadrant, we call it a disconnected care experience. They score below our international threshold of all the 90 countries. Here you have a fragmented care experience, and here, well, you could summarize it as a connected care experience or a partially connected care experience. So we see, again, 8 countries doing well based on what patients tell us, but the UK is the patients indicate they have a disconnected care experience, while in Germany and Australia they have the fragmented care experience. Interesting, based on their value on a person-centered care approach. Now we're going to look at the service coordination for the first bow of the rainbow. If patients experience that the care at the individual patient level in the interaction with the provider is well coordinated. And again, we see UK, a disconnected care experience, and also Germany. That's interesting. They were here in the previous slide, and now they're also indicating that on organized in a micro level, they have a disconnected care experience. And again, Australia, a fragmented care experience. Professionals how do patients think that professionals coordinating their care among the different providers they see? And again, we see UK, they experience a disconnected care experience, Germany as well, and Australia again, a fragmented care experience. Interestingly enough, which I can't show you in this slide, but you can, within a dashboard, you can drill down on these countries and see different clinics, and then you see also the pattern of the different clinics, and then it gives information how you can improve it and what different patients say in different contexts and regions, which makes it interesting. Organizational coordination experience. This is also quite interesting because my assumption is that this is one of the main barriers of starting coordinating things across the globe. And here you also see in the UK, they indicate it's a disconnected care experience, in Germany fragmented, and also for Australia a fragmented. So patients tell us that when they visit different organizations, they experience not that their care trajectory is coordinated, which is quite interesting because I didn't expect this from these 3 countries, especially not from the UK and Australia, because I thought they were really ahead on this agenda. But we see something different if we ask it patients, and this doesn't match with the policy papers we have around integrated care, which makes it quite interesting, I would say. And there's a lot of more statistic behind which I won't show you. We can also indicate which providers they have seen and so forth and so on. This gets too technical for today, but just give an overview of what is possible if you start measuring it from a patient perspective. We also did the same plot, same data for providers, and luckily enough there is a correlation between what the patient says and what the provider says. So, and so that I'm happy that there is a correlation, so you can also use the experience of a care provider is basically some sort of an assumption how we are doing. So, from theory to practice, to sum up, we now have the first international validated measurement tool that measures all aspects of integrated care. Why I'm saying all aspects, because we did the review, systematic reviews, we saw all the instruments, and the majority of them are disease specific, are very complex to complete, which make them unapplicable for practice. The reliability, the psychometric properties are also not that well for the majority of instruments. And they most of them lack like a duplicate instruments, one for patients and providers, which is very essential to start understanding the different perspectives and complexity as we discussed. So that's what we have now. We can base that on experience of patients and caregivers. Well, the questionnaires, as I already said, are short and generic, so they are applicable across settings and organization, which makes it useful in practice. Otherwise, you have to design an instrument over and over again. And they have a good construct, validity, and reliability, which, well, as an academic, I think that's very important if you use a measurement tool. And, well, we're going to publish these results in an academic paper later on this year. More on practice side, it provides, well, really hands-on information how you can improve basically the care process for patients. But there are dashboards behind which you can really look and drill down up to a practice level, which gives very detailed information how to improve care coordination experiences across the care continuum, which makes it a very useful tool, I would say, in practice. Are we there yet? No, definitely not. And this is basically the research agenda we're now working on, determine the added value. So here you have the drivers, as we already discussed, basically how things are coordinated, and the enablers. Are the enablers an effect modifier or a confounder? That's the big question. And, well, we already run some analysis on this based on also to find out the correlation between triple aim, so cost data, health data, clinical outcomes, and quality or more experience kind of related quality data. And I can already tell you that there is a correlation between how care is coordinated and the clinical outcome. And that's something which is, well, that make me jump around my office, because this is completely lacking in the current literature. And now we're exploring how these enablers are making the effect more or less within a certain context, and that you can apply across the different countries, and then you go, as a researcher, you can go completely crazy with such a data set. But this is important. We start to understand this, how this works and how we can improve the outcomes. Well, this is basically some kind of promotion. If you want to work, you want to use it, we're happy to work with you, because I want to have an international benchmark on care coordination, and this is how we apply it in practice. We have it in several languages already, as you saw, and we have it already in Chinese, and now we have to move on with other countries. This is basically the process, how we run it and report back the information. And, well, it gives a lot of evidence also for practice to give real hands-on information. Well, and if you want to determine the added value of an approach, we use these kind of evaluation models. It depends a bit on the data set that's already there to really start understanding how an impact by coordinating care is created. But it depends also a bit on the phase in which your project or organization is, which kind of methods we can apply. So, to sum up, I think if you are interested in using it, please contact us. We are happy to work with you. And if you want to read more, have a look at the website or Twitter, or download my thesis. And, well, this is basically it. Thank you very much.